Okay, good evening, everyone. We'll get started. My name's Chris. I'm one of the senior physiotherapists at Apos Therapy. Just a little bit of background of myself. I've worked in both the NHS and private practice, just treating a wide range of musculoskeletal conditions, and I've worked for Apos Therapy for the last couple of years. Um, just to let you know what we're going to cover today, it's everything you need to know about knee pain. So we'll talk a little bit about the knee and the anatomy of the knee, and what corresponds and what can influence knee pain, what type of symptoms can occur around the knee, and what conditions can cause these, what are the underlying causes of knee pain, what can happen if you don't address the knee pain, and an overview of all the different treatment options available to us. And then we'll talk about Apos therapy and what we do here in the London clinic. So how to use this webinar. So this evening, you'll all be able to hear myself, but I won't be able to hear you, so you're all on mute. We will be asking questions throughout the webinar, but if you have any that pop up as we go along, please write in the webinar window to the bottom right hand of your screen, and we'll answer things as we go along. There will be webinar polls as we go throughout the webinar, so we'll be asking interactive questions, and so we'll be asking your answers. These are all anonymous and unidentifiable, but we'll be sharing the results with the whole group. So the first poll before we get started is, how would you describe your knee pain? So we'll just give you a minute or two just to click on what most represents yourself. Either mild, moderate, or severe. We'll just wait for the results. Just click on what one. Okay, so we can see from the poll results that 44% of you actually report it as moderate pain. So it kind of sits between the two. There's lots of severities of knee pain. So we'll talk a little bit about the different severities and how people describe their pain in a little while. But that's quite a high percentage of you noticing that it's obviously influencing your daily life activities enough to call it moderate pain. Okay, so the knee is a very complex joint. We'll just play you a little animation here. It involves much more than just the bone and cartilage. So as you can see from the animation, the long thigh bone meets the shin bone, and in between you have what we call the cartilage or meniscus that sits in the middle, often called like the shock absorber of the knee. Then you have the ligaments and the capsules that wrap around the knee, providing it with some stability, and often gives your knee a bit of feedback and tells the brain what's happening around the knee joint. And then you can see layer after layer of different muscles, and these are the really important things that actually control how the knees move and provide stability around the knee, and often sometimes the cause of some pain around the knee, but often very influential in reducing the knee pain. So what type of symptoms do you experience in the knee? Again, this is our second poll, so just we'll give you a couple of minutes just to put in what best experience represents your knee pain. So just put in the poll in the bottom right hand of your screen. Okay, so just to feedback on the results of that poll, 89% of you report it's pain that you experience, 44% report it's noises, which is a very common thing coming from the knee, lots of different causes of noises around the knee joint, 11% knee swelling. We'll talk a bit about these, the causes of these in a second. 33% knee instability and 11% knee locking. So we'll go on to now to talk about these different symptoms and how and why these are caused. So what type of symptoms occur around the knee? As you said, most people experience knee pain, 89% of you, and again, a huge percentage of that moderate or severe knee pain. Pain is obviously a subjective and a very personal experience. So it can range from anything from a dull ache to something that's quite sharp and agonizing knee pain. And again, as we'd already described the different severities, so it can be just a mild ache that lasts all day, or it can be something sharp that happens when you're doing a particular movement. Some people find it very hard thing to describe, which is why we often use it in conjunction with other things, questionnaires and things, to help us monitor patients' pain levels. Stiffness, it can be felt from the actual joint itself, with our degenerative conditions, our osteoarthritis, which we'll come on to discuss a little bit later, stiffness within the joint. Sometimes from the actual muscles that are around the joint can provide and cause the stiffness, because they're actually tightening up to try and protect the joint. Sometimes with the arthritic conditions, it's actually the fluid within the joint that becomes a little bit thicker and a bit more viscous. So that's why people experience it. It takes a while to get going in the morning, and that's what's causing the stiffness. Swelling, it can be there all the time, or it's something that we can come and go depending on the activity. So you might have an injury, you might have twisted and fell on it, and obviously that's going to cause some swelling, but that's normally an acute swelling. Something again with our degenerative or osteoarthritic changes, it's more what we call an effusion. So the actual fluid that sits within inside the sac of our knee seeps out into surrounding areas, so it often looks puffy and swollen. And again, that can be there on a consistent element, or it can vary depending on how much you exert forces on the knee. Noises and crepitus. We all describe different funny noises coming from the knee. Fun things like clicks and cracks, some crunches, some grinding, lots of different causes of it. Sometimes it's just tendons and things moving around as we move the joints. Again, with our osteoarthritis and meniscal injuries, we find that the joint doesn't glide nice and smoothly, so we call it crepitus, where it's not a nice and smooth movement, and you hear some crunching sounds. Instability, often there's a couple of reasons why people feel instability. Often from ligament injuries. If people have a bad trauma to the knee and their ligaments are damaged, the feedback that they're getting to the joint is not great, so that's not telling their muscles to work effectively, but also the actual stability that the ligaments provide is causing that instability. When you've had pain for a long time and the muscles stop working as well, then that's going to give you the feeling of instability, which we'll talk about a bit more later on. And locking, quite not a very common symptom. True locking is very rare. Actually, it's very painful, and actually it means that you mechanically have to unlock the knee, and this can actually be misjudged in terms of people describe it as stiffness. So if they can slowly work out the knee stiffness, it's not true locking. True locking is when you actually mechanically have to unlock it, and normally requires some kind of surgery or medical intervention. Okay, so now we'll go on to talk what the underlying causes of knee pain are. So we've already touched on it briefly. Joint changes, so the changes of the actual joint surfaces that actually meet, say, on top of the shin bone and the bottom of the thigh bone. So people talk about wear and tear or osteoarthritis, and the meniscus, so the two shock absorbers in the middle of the knee that stops the joints rubbing on each other. As we get older, they gradually get softer, which is the normal process. Our bodies just age. But as this cartilage gets thinner, then it can have a knock-on effect to our biomechanics, and then how our muscles are actually functioning around the knee joint. But osteoarthritis, again, is something that is probably one of the most common causes of knee pain as we get older. Injury. So again, if there's an acute injury, if we've fallen over or if we've twisted the knee, funny, that's going to cause some acute inflammatory responses, which is going to cause pain on the soft tissues and on the ligaments, but sometimes the joint itself. It can be something from a big sporting injury like in football, or it can be something very minor in our a little bit older patients. Just something as simple as changing direction or getting up from a chair can just put that excessive force through the joint and cause a bit of an inflammatory response. Tendon irritations, often associated with abnormal movement patterns and changes in the muscle activity. So again, if our biomechanics and if our alignment is altered, that can put excessive stress on different tendons and soft tissues, which can cause pain over time. And the patella and the kneecap, so the kneecap sits on the front of the knee joint and slides up and down a little groove. And just because of how the knee works, and it's a bit of a lever, it's a very complicated joint, as we discussed earlier. It's very much a very common condition to get the kneecap causing the irritation and pain, just because of sometimes it's muscle imbalance that's causing the pain, but again sometimes it's the more degeneration behind the kneecap. So the sliding up and down of the kneecap isn't as smooth, and that can cause your pain, especially on things like going up and down stairs or bending down to a cupboard. So one of our listeners has just asked a question. So is surgery to realign the patella successful, and what's the recovery time? There's lots of different types of surgery on the knee, which we'll talk a little bit more later. But surgery to realign the patella, sometimes it's like they change the position of where it attaches. It can be successful. It's often a long process in terms of the rehab. And again, what we know from research is that actually, yes, from a surgically point of view, the mechanical element can change, and so they might help with the alignment of where the kneecap sits. But it's really important that the muscles and the soft tissue overlying that are contributing hugely to how the knee is working. So you do have to address both components to it. I would always go, the surgery is always a latter thing that we turn to as a last resort, and it's more important that we try less invasive measures first. Okay, so our third poll this evening is: have you received a diagnosis from the GP or another healthcare professional regarding your knee pain? So just type in the poll yes or no. Okay, and it's very good to see that 91% of you have said yes. So you've actually been to see someone about your knee pain, and they've actually diagnosed an issue. It's really important when we talk about knee conditions that you have the correct diagnosis, obviously, in order to guide what treatments are going to be the most effective for you. If you have the wrong diagnosis or no diagnosis, it's very hard to guide and to make the decision what treatments you're going to respond to best. So that's very good. Okay, so what will happen if you don't address your knee pain? Now we know most injuries, most conditions, if they're new, they normally get better. The body's designed to heal itself. So over the course of maybe 4 to 6 weeks, if it's an acute injury, it normally gradually gets better. But sometimes these things don't, and there's a reason for that. They become a bit more chronic, and there's got to be a reason for that. Maybe how the muscles are working, how the joints, what's actually causing the pain itself. But if pain goes on for longer, the pain generally continues to increase. Obviously, with the pain increasing, what you tend to do is change what your habits are. So you might stop doing your hobbies, you might change your function, and you'll reduce your activity levels to compensate. This will obviously eventually have an impact into your overall quality of life, and then you have a bit of a vicious cycle. So then you'll do less, and your muscles will work less. Your joint will be less able to um, function, and then we go round and round and round. So this actually might cause more of a structural problem in the long term, because obviously if you're not using your knee, then obviously the muscles are going to be causing more pain, which is going to be bracing around the joint and causing more irritation and pain and degeneration. So poll number 4, what treatments have you already tried or are you currently trying at the moment? Again, I'll just give you a couple of minutes just to fill in your answers, and then we'll feed them back in a second. Okay. So just make sure you're filling in the webinar poll on the bottom right. Okay, so we'll just feed back the results of that now. So 69% of you are using or have used pain medications or had injections. A small percentage of you, 8%, have used podiatry, so probably some insoles or inserts. 77% of you, physiotherapy or some exercises, which is good, and 15% some surgery, so either arthroscopy, so keyhole surgery, or a knee replacement. And then 8% osteopathy and chiropractor, which is possibly similar to the physiotherapy. So we'll go into now the different types of treatments and explain exactly what each of them are. So with medications, they can be very effective. So again, in the short term, to try and calm any inflammatory process down, to almost cover up the pain, to enable you to carry out your normal activities, is very effective. They are There are obviously possible downsides. There's the possible side effects depending on your other medications and your general health. They often are short acting in terms of you have to continue to take them, and sometimes you gradually actually climb up the analgesic ladder in terms of needing stronger and stronger painkillers to actually to control your symptoms. So there's pros and cons, but say normally the first line of defence is to go to your GP, and that's their role, is to deliver and give you medications. Injections is obviously the other thing. So there's two main types of injections. The steroid injection, very common. Again, very good in an acute phase. So if you have an acute flare up, to try and settle down the symptoms and that inflammatory process. And hyaluronic acid, which is it's a natural body's fluid, so it's like lubricating the joint a bit more. Often patients experience a relief in their symptoms when they've had it. Again, the downfall of injections is that the fact that they're quite invasive. You've obviously got to inject something into the body, which has its inherent risks. And again, the research behind how long they actually last. Some people have no response at all. Some people it lasts for a couple of weeks. Some people 6 months. So it's very varied on an individual basis. So again, very good in certain situations, but they're not addressing the underlying cause of your knee pain. Physiotherapy, which most people have actually had or are having at the moment, very common. And again, it's trying to address the muscle and the soft tissue elements of your knee pain. So they might give you some exercises, try and build up the quadricep muscles, or try and give you flexibility exercises, or it might be some more manual therapy, so some more hands-on approach to try and loosen up some tight tissues and get things moving a bit better. Again, even as a physiotherapist, again, we have our limitations in terms of how we can influence the knees. Sometimes they respond very well to exercises, but sometimes because we can't influence the mechanics and how the joint's actually made up, we sometimes actually cause more pain when people are exercising. Sometimes we're not very good at actually doing our exercises. So you need to get a high number of repetitions in order to get the benefits from them. So again, if they're painful, then you're less inclined to do them, and that's obviously going to lead to an ineffective treatment. Osteopathy in chiropractor, much the similar vein of physiotherapy, often some manual therapy and some exercises to try and address the same things as physio. Supplements and nutrition. Now, there's lots of different supplements out there, varied in terms of their effectiveness, and it's very hard to kind of give a definite answer on what ones work and don't. You have the glucosamine and chondroitin as supplements, cod liver oil. Again, they vary so much that there's no research to say that they work or they don't work, but they're very they're not invasive. So sometimes my recommendation is to actually try them. If it works, then brilliant. The important thing is that it helps you. So that's supplements and nutrition. Podiatry and orthotics. So as we said, people sometimes have insoles or some orthotic inserts into their shoes. Again, very good at addressing the biomechanical side of the issue. So some people have overpronation and the changes in their mechanics, so that can really help with that side of things. Very passive in terms of their limitations is that by supporting the foot in a certain position, then yes, that can influence the mechanics, but as soon as you take your foot out of it, then you're back to square one and you haven't trained the muscles and how they're meant to work more effectively. And surgery. So last but not least, surgery. Lots of different types of surgery. As we said, some realigning the patella is one surgery that they do. Arthroscopies, which is a very common one, keyhole surgery, or then you have the more invasive ones, the partial knee replacements and the total knee replacements. Again, always a last resort. Obviously, it's very invasive, and the rehab process afterwards can take a very long time with varying degrees of success. There is a right and a wrong time for such surgeries, so it's important that, again, your GP and your doctors or your physiotherapists guide you in terms of when is appropriate time to actually seek more invasive methods like surgery. Okay, so this is what we again we'll talk about a bit later on about our assessment. Is it's really important to address when the patient's appropriate for surgery or not. Is there any questions regarding any of these treatment options or anything you want to discuss at this phase? I'll just give you a couple of minutes just to write down in the webinar window, and then we'll feed back and continue. Okay, we'll just give a couple more minutes just to write any more questions, and then we'll move on. Okay, we'll continue now. So we'll now move on to talk about APOS therapy and how we treat our patients here in the clinic. There's three components to APOS therapy. It's a personalized patient pathway. There's obviously the biomechanical device, if people have actually seen advertisements of it before, and the important thing is it's part of daily life, so it's very functional treatment. So the first component, as I said, we're all specially trained physiotherapists. So as we spoke about earlier, how diagnosis is very important. When you come for your initial consultation, you we carry out a full physiotherapy assessment, looking at your gait, your range of movement, and having a look at your gait deviations to see whether you're suitable and how you fit in with the treatment. We have certain outcome measures, so we have a special computerized computer system that actually analyzes your gait, so it actually guides us in terms of suitability for the treatment. And again, we can guide you in terms of surgeries and whether that's the appropriate route to go down as well. And you fill out different questionnaires that look at pain and function and quality of life, which we can then monitor that throughout your treatment. And so throughout the treatment, we're continually monitoring and adapting things to make sure we're optimizing things. The actual device itself is essentially the shoe is just something that enables us to attach the pods on the bottom. Okay, so we'll show you a picture in a second and explain a little bit more, but we can change the positions of the pod very specifically to each patient, so it's very personalized, and by changing the position of the pods you can change where the force goes and therefore reduce pain in the joint. The second part of after you've reduced pain is obviously to challenge and to train the muscles around the joint to work more effectively. So because it's on a slightly curvy surface, your muscles are asked to respond, and therefore you get a carryover and a benefit into your barefoot walking. So as you can see here, there's lots of different variations of the pods and things that we can change. The actual device itself, we can change the positions of the pods, so we can move it around forward, back, side to side to change where the force goes. We have different levels of convexity, so going from a fairly flat pod and gradually higher and higher. So as your muscles get better at controlling the device, then we can challenge your muscles further. And there's different weights and spaces that we can add in, again, to further challenge your muscles, but also to give you more feedback to the joint as well. Okay, so here we have a patient that's at their initial consultation. I'll play it a few times because it goes quite quick, and I'll talk you through what it shows. So this is a lady with bilateral osteoarthritis on the right side more than the left, and patellofemoral arthritis, which is basically the kneecap joint we said earlier. So on the left hand side, you can see her in her barefoot. She's walking in a lot of pain. She's reporting a lot of pain when she's walking, which is why she's limping quite heavily, and obviously walking quite slowly. Now, at the same time, on the right hand side, this is 10 minutes after we've calibrated her into the special biomechanical devices. You can see that her walking obviously speeds up a lot. She's a lot more comfortable, and you can see she's a lot more symmetrical, so that limp has actually reduced. More importantly, she's reporting less pain because now we've taken the pressure away from the areas that are initially causing her pain, and at the same time we're training the muscles up to start working more efficiently. I'll just play it one more time for you. So again, on the left in her barefoot, and on the right again in her once she's calibrated very specifically to her, you can see how her muscles and things are working a lot better. And obviously what we're trying to do is we want to get this benefit into her normal barefoot walking over time. Okay, so as I say, the third component is that it embodies functional rehab. So it's very easy to use. You'll be wearing the devices around the house or at the office, or just a short period of the day in your normal activities. It's a mixture between actually time on your feet and sitting down. You're not continually walking in them, and it can be carried out wherever it fits into your normal life. Okay, so it's very easy to use, which is why it works very well. And so the actual package is actually over the course of the year. So we see our patients over the period of the year. Initial consultation followed by the first follow-up will be about 3 or 4 weeks, and then we can slowly spread out the appointments over the course of the year to corresponding to how we need to adapt the devices to show your progression. Okay. So this is the patient, the same patient, a third follow-up. So she's about 5 months into the treatment now. And again, on the left-hand side in her bare foot at the initial consultation, and on the right-hand side, the same lady, again in barefoot, so she's not wearing the devices now. You can see that that benefit that she had when she was actually wearing the devices has now transferred into her normal walking pattern. So again, she's walking a lot quicker, a lot more symmetrical. She's, again, and most importantly, reporting much less pain. So she's back to her normal functions. She can do what she needs to do in a normal daily life, and obviously her walking has improved immensely. Okay, so that brings us to the end of that part. Are there any questions about APOS therapy at all? Again, I'll just give you a couple of minutes just to write in the webinar window, and then we'll feed back. Okay, so one of our listeners has asked, how does this differ from an orthotic? So as we discussed earlier, orthotics and insoles things, again, quite good at addressing the mechanics. One way that it's different is that it's, well, very personal, so we can change it from each patient, which some orthotics you can do. It's on the outside of the device, outside of the shoe, so you have a lot more control of the biomechanics. But most importantly, the carryover process. So because we said it, an orthotic is quite passive. So once you take the orthotic away, it's not doing its work anymore. It's not working the muscles. Whereas in APOS therapy, we're training the muscles at the same time as changing the mechanics and where the forces are in the joint, and therefore we get better carryover process. So we get long-term benefits. Okay. One of our listeners has asked, they said that they're waiting for surgery, and would APOS therapy be an alternative? If I could ask that person to just tell us what type of surgery as well, that would help us. But in terms of surgery, again, this is something that we can, for certain patients, bridge that gap. So they've tried other things in terms of physiotherapy, and before the need for more invasive surgeries like knee replacements and tibial osteotomies and knee arthroscopies, this is a very effective treatment for most patients. We'll just wait for that patient. I'll come back to that one in a second just to see what surgery they're getting. One of our other listeners has asked, does it cure arthritis? Now, again, arthritis is a degenerative condition. It's just basically the softening of the cartilage and the thinning of the cartilage. We can't cure that. We can't change the underlying process, but what we can change is how the body and how you experience your symptoms. So by training the muscles and by changing the mechanics, we can actually, it doesn't matter that there's degeneration and that the cartilage has got thin. That happens over a long period. It's more the fact that your muscles are working more efficiently, so you can get back to your normal activities and your pain is experienced. So that's how we can help. Okay, so the listener has got back to us. So it's the knee replacement they're waiting for because of osteoarthritis and a Baker's cyst. Again, it's something that it's certainly worth seeing as part of our assessment. At APOS therapy, we do a free initial consultation for all of our patients to see whether they're suitable for the therapy. So again, they can come for an assessment. They can see have a full consultation with our physiotherapists, and we will tell them there and then whether APOS therapy is something that we'll be able to help with, or whether for this patient, again, knee surgery or knee replacement is going to be the better option at this stage. And we use certain things to guide this. Going back to that patient again, we've successfully postponed surgery for a lot of patients awaiting total knee replacement when they think that there isn't anything else to actually help them. It's something that we treat on a day in, day out basis, so it often is something that we can really help with. Okay, one of our listeners has asked, do I have to wear them all the time? The important thing about Appos therapy is it's very again, it's very easy to use, but you don't have to wear it as your normal shoe. This is a very small section of your daily activity, so normally about an hour a day. Again, it varies on the patient and how long you've been doing the treatment. But you'll wear them for a small percentage of time, and actually during that time it's training you. So in the same way as you go to the gym and get the benefits afterwards, when you take them off over time, over the course of a few months, you'll gradually get more and more benefit from them, and not need to wear them as much. Okay, any other questions at all? Okay, one of our listeners asked, can it be used for back pain? Again, just in the similar ways, in the same ways, by changing the positions of the pods, we can change where the mechanics and where the force goes through the joint. So it's something that we treat. Again, most people with knee pain often actually have back pain as well. So we treat the two conditions together. We treat anything from the lower back downwards because it actually affects the whole. We call it kinematic change, just a fancy name for the whole body, from the ankle, the knee, the hip, and the lower back. Okay, so again, once on the other listeners has asked, how does it affect the other joints, such as the hip and the ankle? So again, we have to look at the patient as a whole. So when we're calibrating the device, we have to see obviously if there's any other conditions we have to take into consideration. But again, we treat all of these joints, so it's something that we can help not only with the knee, but actually with the other joints as well. Okay, one of our listeners has asked, is it on the National Health? Unfortunately, it's not on the National Health at the moment. We are soon to be beginning a pilot study with the National Health Service, which obviously will build up it's a trial, it's a clinical trial. So they'll do a spectrum of patients, and they want to see the results of these patients in the long term. So it's nothing that's going to be on the NHS in any time soon, but it's certainly something that we'll be looking towards in the future. But a lot of our patients actually come to us have insurance policies, so we're covered by all major insurers, Bupa, WPA. Again, if it's something that you want to come to the assessment, we can guide you on what insurers actually cover the treatment. But yeah, most insurers actually cover the treatment. One of our listeners has asked, does it stop further degeneration of the joint? Now, in principle, again, by changing the loads, we can slow down that vicious cycle. So we know there's a bit of a vicious cycle for knee arthritis and degenerative changes, because there's excess load on part of the joint. Your muscles brace around the joint, which increases the load, and that's the vicious cycle. If we can stop that vicious cycle, then yes, technically we can slow down that degenerative process. And another listener has asked, is it an ongoing lifetime treatment? It really varies per patient, again, depending on your age and the actual cause of the condition, what type of pathology you've got. Something like osteoarthritis, when it's quite a chronic condition, and again, it does generally tend to get worse as we get older. It is something that we see a lot of our patients do come back and see us, like they go to the dentist and have a checkup to optimize the treatment. We often see that, or we see patients that we treat for the year, then they go away and they're very happy, get on with things, and then their conditions deteriorate again, and then they come back and see us. So lots of different variations. Okay, any final questions before we finish? Okay, we'll just move on. So if you'd like any further information on APOS therapy, you can email us on information@apostherapy.co.uk, or you can visit our website if you haven't already. It has lots of information about the treatment and the case studies and different research, etc. So please visit the website, it's very useful. Um, the last poll is, would you like to find out any more information about APOS therapy? If you could just put in on the poll yes or no. Okay, just give you a couple more seconds to put that answer. Okay. One of our listeners has just asked, so they're on the waiting list for surgery. In terms of assessments, we have available initial consultations straight away. So if you'd like to get in contact with us, we'll be able to guide you in terms of when the available slots were to be assessed as soon as possible, and what ones and where your nearest centre will be most appropriate. Okay, thank you very much for joining us this evening. And like I say, if you want any further information, please get in contact with us and we'll be happy to help you. Hope you've found it useful, and we'll look forward to seeing you soon. Goodbye.